All right. So, welcome to the first ever Brosides series with the Vedala brothers. Our purpose with this is to really come up with a weekly series where my brother, Dr. Veer Vedala, and I will basically be talking about a selected topic. And we're going to keep it pretty simple. We're not going to make this too complex. Our hope is through our conversation you guys will be able to understand more about a selected topic. Of course, the majority of these will be medicine, healthcare related, but hopefully, this is something that you guys will find effective. And without any further ado, I want to welcome my brother, Dr. Veer Vedala, who is also a practicing family medicine physician, but he's also board certified in family medicine, obesity medicine, lifestyle medicine, and also menopause, correct? Menopause treatment too, right?
Certified is a strong term, sir. I just had an interest in it and learned more about it.
You
Let's
you
go
don't
with
have to
that.
call me sir. That's okay. You don't have to call me sir. That's
Dr.
fine.
Vidala, please, sir.
No,
Please.
please,
I'm so
Veer,
grateful to
stop.
be on your podcast.
Veer, stop. 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 All right.
All right, let's go. Let's
So,
get this thing going. Bro side,
okay. So, yeah. So Veer
herb side, but
actually
a bro
went
side.
to the obesity medicine conference just a couple weeks ago, where he heard of a new term known as male obesity-related secondary hypogonadism, or also known as the
Yes.
acronym
We're calling
MOSH.
it
So,
MOSH.
MOSH. So, Veer, tell us a little bit about what MOSH is.
Yeah, so I think this is very interesting, man. I mean, I know we like talk about patients, especially in the world of obesity. When we have a mutual interest in men's health, and that's why I went to this talk. So it was like very interesting to learn more about like if there's anything new to learn about testosterone deficiency and replacement and stuff. And we've had a conversation like this before with one of our colleagues, Dr. Alexander Jones, and how there's an over prescribing of testosterone and especially in the young patients, and it doesn't come out without risk, infertility, DVTs, pulmonary embolism risk, polycythemia, AFib, stroke, right? And it's something that we've seen a lot in our practice. And so I went and I was just very surprised about this new term, which I haven't heard before. Have you heard of MOSH before?
I've never heard of it. I know that
Yeah.
there's always been some research that's been done regarding obesity and hypogonadism in males, but never heard of this term actually myself.
Yeah, so I was like, MASH? I'm like, no, no, not MASH, not metabolic associated steatotic hepatitis, or there's NASH, then there's MASH, and now there's MOSH. But but basically, you're right. So what it stands for is male obesity associated secondary hypogonadism, and it's actually very interesting. The thought process is as we have more adipose tissue, the adipose tissue actually overexpresses aromatase, right? And so you're
Mhm.
converting testosterone to estrogen. And by doing that, the obesity driven insulin resistance is also lowering the sex hormone binding globulin, or the SHBG, right? And what happens is the testosterone, the total testosterone is going to be reduced here because we've got the testosterone bound to SHBG. And if there's less SHBG, then we are seeing reduced total testosterone. So it's kind of like a pseudo hypogonadism, right?
Mhm.
So if we just get the total testosterone and check somebody if they're below 200, it's going to be low. And so we do have to do the entire workup of a testosterone deficiency. And so basically the patients that we see, we'll have patients that come in, let's say 32-year-old guys who are like, hey, I have erectile dysfunction, and they're overweight or obese. Their categories are like class 1 or class 2. We'll go ahead and get the total testosterone. We'll do it twice. It'll be less than 200, and they'll want to be on testosterone replacement. But then when we do the follow-up testing, because it's weird to have these young guys on low testosterone, right? They're not supposed to be that way. When we do the follow-up testing and we get the FSH and LH, if this was like a primary hypogonadism thing, where yes, that there is not secretion of testosterone from the testes, you would assume that the FSH and LH would be high. The brain would be telling the testes, be like, hey, keep keep pumping out testosterone. But then that's where the mix-up is, and then you'd go like refer to genetics and karyotype and all that stuff. But then the testosterone is still low, but the FSH and LH are normal, then you're dealing with, maybe sometimes secondary hypogonadism. And then we start thinking of pituitary tumors, and, we get brain MRIs and make sure that none of that's happening. And we've just heard about that recently, like we had that conversation with one of the other docs that was talking about his own experience recently. And
Hmm.
when he had like an elevated prolactin, had a prolactinoma, right? Um, but what if all of that comes back normal? What if your MRI is also normal too? Why does this patient have low testosterone? And I think this MOSH actually it's a very interesting explanation, because we've known this. We've known that, hey, if you have excess weight, then we're gonna see low testosterone, and you'd send him into urology, and the urologist is like, this guy doesn't need testosterone replacement. He needs to lose weight, right? We've seen
Hmm.
that. We've had that in some of our patients. And I think this just clarified it to me, like, this is actually what this means. Because now, instead of putting these patients on testosterone replacement, which I think there's still a place if, you're really working on lifestyle modification and weight loss, and if it's really truly due to erectile dysfunction and you still see really low levels like 140s, then maybe there's still a place. But first line therapy should actually be weight loss, lifestyle changes, resistance training, maybe the GLPs to get them to a lower weight, because then you have less adipose tissue, less aromatase conversion, increased SHBG. And then when you get a total testosterone, you'll actually see it be normal, right? So that's why in the patients that have elevated BMI, they want you to get an SHBG and a pre-testosterone level so you can actually confirm this. But
But I kind of feel
that's the
like
gist of it.
at the end of the day, doing all that workup, like the imaging, all the genetic testing, is that really necessary? I mean, if you have someone that has a BMI of 35 and then you check their testosterone and it's low, and then you can check the LH and the FSH, I mean, you're there, right? You basically have confirmation. But did they actually recommend doing all the diagnosis of exclusion workup, like the MRI and the genetic testing?
Yeah. So in the lecture itself, that's one of the things they like stressed and they didn't want you to miss was, hey, these prolactinomas are not as uncommon as you think, and
Mm.
don't miss it. And the other thing
Okay.
they really stressed was testosterone's not a benign therapy, and you really need to be making sure that there's not, there's full informed consent for patients before they get started on it, because a lot of these guys will. And then the other thing they picked up on is make sure, if you get like people coming in and they're saying they have low testosterone, make sure they're not using things like exogenous steroids and stuff, right?
Right.
And they went to a whole other realm with that for uh, the people that are like bodybuilding and all that thing. But that's one thing that they wanted to stress, is it's not a benign therapy, and that we really need to really counsel our patients regarding risks and benefits before we start this.
And I think it seems like
Oh, and then
another,
they mentioned sleep apnea. Sleep apnea can apparently
yeah,
lower your testosterone level. Right.
which, we've already kind of, there's already research out there that was showing untreated sleep apnea could affect sexual dysfunctioning. But I think it looks like that one of the other aspects of this new diagnosis is terminology. It's also, again, to kind of help emphasize the functioning or the true need for testosterone replacement. It's not just that everybody or anyone can get it. It's actually people with true primary hypogonadism that really need it, but not just your average patient with a BMI of 35 and low testosterone. I feel like that also is playing, or at least to help expound on that, is also probably one of the reasons why this terminology is coming together.
Right. No, I think that's absolutely true. But not, as you get patients get older and you have our like 60, 65 plus patients, it's not a risk benefit thing, right? Like, let's say somebody
Right.
comes in with severe osteoporosis, you check their testosterone, their levels are 75, right?
Yeah. Yeah.
And that's, I don't know if that's considered primary, at this point, it's possibly secondary hypogonadism, but those patients I might actually benefit from it, right? And so
Yeah.
we try it. The problem is getting people off testosterone when you start that. That's a really hard thing to do, right?
Yeah.
So in this situation, you would start them on testosterone, you would do the lifestyle changes, they would lose weight, they would start exercising regularly, and then you would slowly taper them off. I think that would be the way to go if you do start.
Okay. Well, I mean, I think it's a really relevant discussion to have, specifically within both the medical community, but also just within the general population, specifically looking at this relationship between secondary hypogonadism, low testosterone, sexual dysfunctioning, and obesity. And it's really something that we've known for a while, but I think now there's finally a way to put it all together. And I think that's really where MOSH comes from. So it's important that people know about this. Thanks for bringing this up. This is a pretty big topic, and I think we all realize it, but I don't think we really utilize this kind of terminology and the importance of putting this terminology together in terms of understanding when it is appropriate to treat obesity to treat secondary hypogonadism and when it actually is appropriate to use testosterone instead of just throwing everybody on testosterone just for the sake of it.
Yeah, no, absolutely. I think half the time when we get patients that come in from low T clinics that have no follow up, no risk benefit discussion, I think that this is it's the problem. It's not a benign therapy that everyone thinks it is. So
Mm,
yeah, no, it's great. I think we always have something new to learn, right? This at least this puts a name to it, and we can explain it to our patients in a understandable way.
of course. Well, this is our first Broside series with the Vedala brothers, and thank you a lot, Veer. This was really a really interesting topic. Of course, we'll be back with another episode again next week. We finished our first one. Hey, two thumbs up, and
Hey,
tune in for the next episode. And we'll see you again next week. Thank you.
bye, guys.
Bye, guys. If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway in a review. See you next week.